Hello, this is Dr. Marcelo Kugumas. On behalf of the Chronic Liver Disease Foundation, I'd like to thank Madrigal Pharmaceuticals for their support in bringing you this educational content.
Hello, and I'd like to welcome everyone to our podcast today entitled Resmetirom, the first FDA-approved therapy for adults with non-cirrhotic fatty liver infiltration / MASH and moderate to advanced fibrosis. My name is Dr. Stephen Flamm. I'm the Director of Clinical Research and the Medical Director of Transplantation Services at Rush University Medical School in Chicago. And I'd like to welcome my panelist, Dr. Naim Alkhouri. Naim, would you please introduce yourself?
Thank you, Dr. Flamm, for having me. Naim Alkhouri, I'm the Chief Medical Officer and Chief of Transplant Hepatology, Director of the Steatohepatitis Liver Program at Arizona Liver Health in Phoenix, Arizona, and I'm very excited to be here with you today to talk about Resmetirom.
Me too, Naim. Naim is one of the world's experts in fatty liver and MASH and is an ideal person for us to discuss today this very important topic for those of you who are practitioners and care for patients with MASH all around the country. Naim, would you spend about 1 minute and give me your perspective on fatty liver and MASH, and then we can move quickly into this very important new advance for therapy.
Yeah, I mean, as you know, fatty liver or MASLD affects about 35% of the adult population in the United States. And MASH, which is the aggressive form of the disease, affects about 20 to 25% of individuals with MASLD. Once you have MASH, that puts you at risk of fibrosis and potential progression to cirrhosis and its complications. And I think that's why 2024 will always be a historic year for us, providers that take care of patients with MASLD and MASH with the first FDA approval of a medicine that can actually treat this condition and potentially slow fibrosis progression to cirrhosis, because historically speaking, all we had to offer our patients was lifestyle modifications, recommending that they lose 7 to 10% of their total body weight. But that's easier said than done. And now we have a liver-directed therapy that can again, stop progression, but also potentially in some patients reverse the disease and lead to fibrosis regression. So very exciting.
So, Naim, fibrosis, which we in the liver world are very worried about in patients, only happens in a fraction of the patients that have MASH, fortunately.
Yes.
And it's very important for us to decide who we're worried about and who Resmetirom is appropriate for by actually figuring out in every single patient how much fibrosis they have. How do you do that?
So we utilize for the most part what we call non-invasive tests or NITs. Historically speaking, we used to rely on liver biopsy, but this is invasive and costly and has low acceptability by patients. So what we utilize in our clinics is blood tests, such as the Enhanced Liver Fibrosis Test or ELF, that can determine the presence of significant and advanced fibrosis. We also utilize imaging tests such as transient elastography. This is a test that can measure liver stiffness. It can give you a number for fibrosis. We call it the liver stiffness measurement in kilopascals. It can also help you determine the amount of steatosis you have in the liver. You get another number called the CAP score. We can also use MRI technology. We can use a special MRI called MRI-PDFF and MR elastography to determine the amount of steatosis and fibrosis. And sometimes in some patients, we have to utilize a combination of these tests to make a definite diagnosis of the presence of MASH with moderate to advanced fibrosis.
So you don't need liver biopsy anymore to stage chronic liver disease like fatty liver, meaning to actually figure out how much fibrosis. You're using these non-invasive tests, correct?
Absolutely. I think this is a key message that you do not need to do a liver biopsy. I can tell you in my clinic, let's say I see 100 patients with MASLD, about 60 to 70% of them will have low liver stiffness on the transient elastography test, and we can reassure them that they just need to focus on a lifestyle intervention and lose weight. And then we have about 30% that may have elevated liver stiffness. And by looking at the entire picture and maybe doing some additional calculations, we can determine the stage of disease in another 20%. 25%. So we only need to biopsy maybe 5 to 10% of patients. So again, you can determine the severity of disease in up to 95% without needing a liver biopsy. And when the biopsy is indicated, I think that's okay. It's better to actually do the biopsy in a few patients and determine the stage of disease and treat them than to say we don't know the stage and not be proactive.
Absolutely right. And it's important for the audience to know that the minority of patients actually have moderate, which would be stage 2 fibrosis, or more advanced liver disease, stage 3 fibrosis, which basically borders on cirrhosis, which is stage 4. But we really worry, of course, about those stage 2 or 3 fibrotics that we think are going to progress very soon to cirrhosis, which we all want to prevent.
Exactly. Yes, that's a very good point that, preventing the progression to cirrhosis is one of the key goals of treatment.
Exactly. And in Chicago, Naim, we do the same thing that you do in Arizona. We also use the blood tests if we have to, the enhanced liver fibrosis test. That's a test that's very underused. I think in the United States, it's relatively accurate in terms of its assessment of fibrosis. And if we have available a transient elastography, which we do here at our university center, we certainly use it. And we measure it here every year on patients. We follow patients annually to see, even if they don't have fibrosis, if they later do. Do you do that as well?
Yeah, this is our approach that, we follow the liver stiffness measurements on an annual basis to monitor for progression. And we also monitor the amount of liver steatosis. And sometimes it's actually good for patients to see that because they did a lifestyle intervention and they lost weight, that there is less fat in the liver.
Now, Resmetirom, this very important advance, the first ever FDA-approved drug, which was approved in the United States in March of 2024, is for patients, Naim, that have stage 2 or 3 fibrosis. The minority of patients with MASH who actually have this moderate to advanced liver disease that border on cirrhosis. So in your practice, what has been the effect?
Yeah, as you mentioned, Resmetirom was approved this year based on the FDA analysis of the MAESTRO-NASH trial. This was a large study that included 888 patients with stage 2 and 3 fibrosis and MASH on biopsy. They're treated for 1 year with Resmetirom. We did a second liver biopsy, and we were able to show fibrosis regression by 1 stage in 25% of patients and a NASH resolution in 30%. So very encouraging results after just 1 year of treatment. We've also shown reduction in liver fat, reduction in liver stiffness, and also reduction in cholesterol and triglycerides. So these are also good effects of the medicine. It can help with dyslipidemia. It's been a game changer in my clinic because now I offer patients with stage 2, 3 fibrosis Resmetirom routinely. I share with them all the non-invasive test data. I show them why they're at risk of progression, and then we have a conversation about starting Resmetirom. I see a sigh of relief on the faces of many patients when they say, finally, we have something we can do, because many of them had fatty liver disease for 5 or 10 years, and they've been told lose weight, lifestyle intervention. They really tried hard, but it's not easy to lose weight. And now they feel like, okay, well, at least I have a chance at slowing the progression of this disease. So it's been actually a good experience.
And I agree. I think it's been a game changer too for these people that we're very worried about. And I also remember, and I remind my team that helps me take care of these people, not to forget about the lifestyle modifications, because in addition to the medication, it's not a replacement for lifestyle modification. We still need to remind patients to try to lose some weight and to continue to keep well controlled their glucose levels if they're diabetic and their cholesterol and triglyceride levels if they have hyperlipidemia. So it's more of a combination approach in terms of therapy.
Yeah.
When you have a patient, Naim, in your clinic that has MASH and you do non-invasive testing and identify them to have stage 2 or 3 fibrosis, and you then think they're a candidate for Resmetirom, how do you actually use it? How do you dose the medication?
It's actually very simple. So it's one tablet once a day, and we have 2 main doses. If you weigh more than 100 kilograms or 220 pounds, then you go on the 100 milligram tablet once daily. If you weigh less than 100 kilograms, less than 220 pounds, then you go on the 80 milligram daily. In terms of side effects, it's very well tolerated. So the 2 major adverse events we saw in the trials were mild nausea and mild diarrhea. They happen in about 15 to 30% of patients, and typically they last between 1 week to 3-4 weeks, self-limited and very manageable. So the discontinuation rate in the clinical trials has been very, very low. And this has been the experience in our clinic. So we've treated about 250 patients so far. And, what I recall from my own patients, only one of them had to stop the medicine. So I think this is very encouraging. And many of the patients feel like they have no adverse events from the medicine. We are seeing some patients come back now and say they have more energy. I've had one patient tell me she used to get this right upper quadrant pain that has been much better since she started. So I'm very encouraged with the results.
Yeah, me too. I think for these patients we're worried about, this has been a game changer in real life. It's so easy to write for this. 80 milligrams once a day for the people under 220. For 220 or higher, 100 milligrams once a day with or without food.
Yeah.
Using this drug is simple. Now, when you start a patient on Resmetirom, how do you follow them? In a normal patient, I would check labs usually twice a year. I would do a FibroScan or an assessment of fibrosis once a year with lifestyle changes. When I say a normal patient, I mean patients before Resmetirom.
Yeah.
Now, since Resmetirom, if you started it today on me, what would you tell me in terms of labs and how would you follow me?
Well, first, I'm sure you don't need to be on Resmetirom, but, if I start a patient today, I think we do the monitoring a little bit more intensive. So we do the baseline labs and non-invasive tests, and then we typically repeat the liver enzymes at 3, 6, 9, and 12 months. Okay. And this is part of it is to assess for safety and make sure there is no signal in terms of hepatotoxicity, which is very, very rare, but we always have to monitor for it. And part of it is to assess for efficacy, and improvement in ALT and AST is still a good signal in these patients. So I always like to see the ALT drop by about 17 units from baseline or more. That's always reassuring for me. Then we do the FibroScan at baseline, and then we do it at 6 and 12 months. And I think you need these 2 time points to assess for efficacy and look at the improvement in the CAP score for steatosis and liver stiffness for fibrosis. And I think, at the 1 year mark, if we see a reduction in ALT and AST, if we see a reduction in the CAP score and reduction in liver stiffness, this is a responder. This is a patient I want to continue. If we see that nothing changed and maybe some of these markers worsened, let's say liver stiffness increased by 30% from baseline, then that would be a non-responder and I may consider stopping. If you have improvement in some of the markers, let's say reduction in ALT and the CAP score for fat, but there is no change in the liver stiffness, I would continue for another year and then assess again. This has been my approach to monitoring and assessing the efficacy of the treatment.
That's a great summary, Naim. I do want to point out, too, to the listeners that we also check the liver panel at month 1. You may see a slight increase of the liver enzymes after month 1 or week 4. A little increase. If somebody's baseline, for instance, ALT is 60, it might go up to 75 or 80. This should not be alarming to the treater because what you then see at week 8 is it usually starting to come down again. And by week 12 and thereafter, it actually often goes below the baseline ALT elevation that there was to start. So the treater should only be worried about liver toxicity that you mentioned if there's a very large increase in liver enzymes, maybe 3 times the upper limit of normal range, which, by the way, in the study was very, very rare. And we do the same thing you do exactly, except I don't do transient elastography at month 6. I wait to month 12 and do it then. But we do everything else you said. And I agree 100%. I get asked a lot of times by treaters, when would you stop the medicine? When would you identify it isn't helping? And there aren't really guidelines on this too much that I'm aware of, but we do the same thing you do. If I saw the fibrosis getting worse, I would probably entertain stopping the drug. But if it's the same or better, I would absolutely move forward and continue on. What about the reverse, Naim? I get asked this sometimes too. Let's say it is working. Say someone went from stage 3 fibrosis at the beginning to stage 1 fibrosis at the end of 1 year. Would you rest on your laurels and say, ma'am or sir, your drug has done its job, and it's going to be retired? Or would you continue on and say, you know what, you have a metabolic disease and it requires ongoing care, just like diabetes or hyperlipidemia? We don't stop those medications if the target metrics are normal. And would you keep them on?
Yeah, I mean, I think for the majority of patients, as you mentioned, this is a metabolic disease. And if the same risk factors are still there, they didn't lose a significant amount of weight, they still have insulin resistance, I think stopping the medicine will lead to disease recurrence and maybe losing the benefits that we achieved. However, even with type 2 diabetes, once in a while, a patient will lose a lot of weight. They are very aggressive with the lifestyle intervention. Or sometimes we see it after, weight loss surgery. And there is that, 5 to 10% of patients where you can maybe stop the medication. So I think that would be the same with Resmetirom. If you lose 40, 50 pounds and your A1C is 0.5, yes, there is a chance. But also, even if you do that, you need to monitor for disease recurrence. So maintaining weight loss is easier said than done. Some people lose a lot of weight initially, but then you look back 4 or 5 years later and they regain it slowly over time. So even if you consider stopping in someone who lost a lot of weight, you need to monitor them for disease recurrence because there is a genetic predisposition. There are other risk factors outside of just weight. So we need to be careful not to tell them that they're good for the rest of their lives.
One other important practical question, Naim, what about GLP-1s? I get a lot of questions about if a patient's on a GLP-1, which that class has shown some benefit to patients with fatty liver in trials to date, although they're not approved. Do you have an issue with using Resmetirom in conjunction with the GLP-1 if a patient happens to be on it already?
No, absolutely not. Actually, in the MAESTRO-NASH trial, we had 15% of patients that were on a GLP-1 and we initiated Resmetirom, no problem. So I think this is a winning combination. If the GLP-1 is being used for weight loss or type 2 diabetes, adding the Resmetirom to help with at-risk MASH, patients with MASH and moderate to advanced fibrosis is perfectly fine. And I think they work in synergy. So I do this routinely in my practice.
I do too. And I want to point out pretty much what you just said to the audience, that these drugs have different mechanisms of action. So at least from a theoretical basis, they are complementary. And it would not be a surprise if they work very well together, similar to how we treat diabetes, for instance, which is with medications that have different mechanisms of action, a different metabolic disease, and together they treat the disease well. And as you pointed out, there were a lot of patients in the trial that led to the approval of Resmetirom that were on GLP-1s, and they did very, very well with the two medications together. So practitioners should not be dissuaded about using Resmetirom if a patient is already on a GLP-1 for diabetes, weight loss, or both. I want to finish, Naim, with one other comment. If you had troubles with access, we can recommend to practitioners all day long about this breakthrough drug for these very needy patients and unmet medical need. But if there are great difficulties getting the drug, it's unhelpful and frustrating. What's been your experience in trying to get medications who are appropriate to medication?
In all honesty, it's been better than expected. We have a very high success rate in converting prescriptions into medicine in the hands of patients. As long as you have clear documentation in your note that the patient not only has fatty liver disease, but they actually have MASH with moderate to advanced fibrosis, and you share with them the non-invasive test data, or if you have a historic liver biopsy, you can also share that. We've had actually a good success. You have to go through a specialty pharmacy. There's a prior authorization, but when the medicine is approved, it's actually delivered to the patient, and they actually work with them on refills. So it's been a good success story. I know that the manufacturer of Resmetirom is trying to help patients decrease copay. They have some assistance programs. So I would say, if you're a new provider and you're thinking about it, make sure you utilize all the resources available to you. But I think it's been a good success story in our hands.
Same here, Naim. We have surprisingly had limited trouble in getting patients these medications. I mean, of course, it's a new medication and there's some paperwork that needs to be done by my office staff. But the vast majority of patients that we think Resmetirom is appropriate for are able to get the medication. And it's not been a tremendous amount of work.
Yep. Yeah, that's very encouraging.
It's very encouraging. Dr. Alkhouri, any summary statement you'd like to make as we close?
I just want to, leave the audience with the message, in 2024, let's do something about MASH, okay? We need to screen high-risk patients, anyone with type 2 diabetes and metabolic syndrome. When we diagnose anyone with fatty liver disease, we need to stage the disease with non-invasive test. And once we diagnose MASH with moderate to advanced fibrosis, we need to start treatment and be aggressive to prevent progression to cirrhosis.
And my closing statement would be this, very similar. I mean, fatty liver patients, MASH patients, sometimes, they don't complain too much. Their labs don't look very impressive. Many times their liver enzymes are normal or near normal, and yet they can have moderate to advanced liver disease. So pay attention to them. Check their non-invasive fibrosis tests every year, even if they don't have a lot of fibrosis, because it can come. And when a patient is appropriate, stage 2 or 3 fibrosis, don't forget about Resmetirom. It's a very important adjunct to our current lifestyle recommendations. Well, I'd like to thank Dr. Alkhouri, my colleague and co-panelist today, and I'd like to thank you for attending our podcast entitled Resmetirom, the first FDA-approved medication for adults with non-cirrhotic but moderate to advanced fibrosis. Thank you very much.